Thank you. Hello. My name is Becky Yarbrough. I am the Cardiovascular Surgery Coordinator. I work at Houston Methodist West Hospital. Just a little bit of a... Thanks to all my people. I've been a nurse for a little over 25 years. I dabbled in med-surg, I dabbled in emergency room, I dabbled in PACU, I dabbled in cath lab, but my love was always ICU. And so that is my background. When I came to Methodist West, I've been at Methodist West. I actually started my nursing career at here, Maine Methodist, and then I've been at Methodist West for about 10 years. And so clearly I drew the short straw, so I'm going to talk to you today about post-operative hemodynamics. So we'll get started. And so our course objectives today, we're going to identify non-invasive indicators of hemodynamic status. We're going to describe the relationship among preload, afterload, contractility, and cardiac output. We're going to describe pharmacological strategies that manipulate heart rate, preload, contractility, and afterload to improve cardiac output. And we're going to understand the modes of action between the different drug classifications used in the treatment of open heart surgery patients. So hopefully you had time to go get your coffee. So we'll start with the cardiac cycle. The cardiac cycle refers to one complete mechanical cycle of the heartbeat, beginning with ventricular contraction, systole, and ending with ventricular relaxation, diastole. So hemodynamics is the flow and distribution of blood and fluids within the body. It literally means blood movement. So typically we measure hemodynamics with the PA catheter. And so you can see the description of where the PA catheter sits. So PA catheter is used to measure hemodynamics, but there's things that we can look at and assess with our patients to tell whether or not your patient is hemodynamically compromised. You don't necessarily need a PA catheter to tell you that your patient is hemodynamically compromised. So just shout out a few things that you would typically see in a patient who is hemodynamically compromised. Don't be scared. Go ahead. Yes. What else? What else? All right. There you go. Drop in blood pressure, rapid weak pulse, change in level of consciousness, cold mottled skin, tachycardia, tachypnea, decreased urine output, hypoxia, anemia, edema. All of these things tell you that your patient is hemodynamically compromised. So knowing your patient, assessing your patient is always going to give you the information that you need with or without a PA catheter. So make sure that you're always looking at your patient before you're looking at that monitor. So cardiac output is literally how well the heart pumps. It's the volume of blood pumped by the heart per minute. And so everyone remembers the famous cardiac output equals stroke volume times heart rate. So we're going to break each of these down today so that you have a better understanding of the dynamics of cardiac output and how stroke volume and heart rate affect your cardiac output. So factors affecting low cardiac output, typically you either have inadequate left ventricular filling or you have inadequate left ventricular function. If you have inadequate left ventricular filling, that has to do with volume. You don't have enough volume to fill those ventricles. So that's going to be from rhythm disturbances because your ventricle doesn't have time to fill. Hypovolemia, there's not enough volume to fill those ventricles. Mitral, tricuspid, or pulmonic stenosis, tamponade, cardiomyopathy. All of those things will affect left ventricular filling. If you have inadequate left ventricular function, that means your ventricles aren't squeezing out that blood like it should. And so you would typically get that from left ventricular ischemia or infarct, cardiomyopathy, hypertension, aortic stenosis, mitral regurg. So keep in mind cardiac output, left ventricular filling, or left ventricular function. So your cardiac index, just to give you an idea of how cardiac index relates to cardiac output, it's calculated by dividing cardiac output by the surface area. This is a more accurate indicator of cardiac function because it's adjusted for the patient's body size. So a tall, heavy person, in other words, needs more cardiac output than a short, light person. So one of the components of our cardiac output is heart rate. Your heart rate is compensatory. That means when the need for increased cardiac output arises, the heart rate increases. A lot like when you exercise, you need more cardiac output, so your intrinsic heart rate is going to pick up to support that cardiac output. In the critically ill patient, though, an increase in cardiac output can have a negative impact. Myocardial oxygen demand increases, your ventricular filling is less optimal, so your cardiac output may actually decrease. You have coronary artery perfusion may decrease. And then likewise, a decrease in heart rate may increase your cardiac output. So medications that you'll typically see for heart rate, depending on mechanisms behind that heart rate. If your heart rate is low, you might need atropine, epinephrine, dopamine, and if you have heart rate that's not responsive to medications, then you would need a pacemaker. For high heart rate, you're going to see beta blockers, calcium channel blockers, digoxin, amiodarone. All right, so stroke volume is the amount of blood pumped by a ventricle with each heartbeat. The factors that affect stroke volume are preload, afterload, and contractility. And we're going to talk about each of those in the next few slides. So when you're talking about preload is the volume in the ventricle. So anytime you think about preload, you want to think about volume in the ventricle. How much blood is in the ventricle before contraction? So if you remember Sterling's law, the greater the volume of blood in the heart chamber, the stretch, the more forceful the contraction, but only up to a certain point. So if you remember the analogy of that rubber band, the more that rubber band is stretched, the more snap you're going to have, the more forceful that snap is going to be. But the more you stretch that rubber band, it can lose its elasticity, and so it won't have that snap. Your heart is exactly the same way. The more it expands, the better contraction it gets, but if you work that heart too hard, it will get floppy and it will not snap back like it should. And so optimal cardiac output depends on blood volume, heart rate, and achieving the appropriate amount of stretch. I like all my animations, they're fun. So factors affecting preload, total blood volume, distribution of blood, atrial kick, sympathetic stimulation, and natriuretic peptides. So total blood volume obviously is the total amount of blood volume in your body. So hypovolemia will decrease your preload, and so that means you have less volume in your ventricle. Or hypervolemia is increased preload, meaning you have too much volume in your ventricle. So distribution of blood, not to be confused with total blood volume. You still have the same amount of volume, it's just where that is at any given time during your heart cycle. So your venous system acts as a blood reservoir and holds the blood in the peripheral system or returns it back to the heart. This is a closed system, so whatever the heart pumps out, it will eventually come back. So vasodilation decreases preload by causing a greater volume of blood to remain in the peripheral system, while vasoconstriction increases preload by increasing blood return to the heart. So atrial kick will also affect your preload. Atrial kick is the force of the atrial contraction. So most of your blood flows from the atria into the ventricles by gravity. As soon as that valve opens, blood just falls into the ventricle. And then what happens is your atrial contraction squeezes another 30% of blood into that ventricle. And so that's why atrial fibrillation can cause a decrease in cardiac output of 10 to 15% because you're losing that atrial kick. So sympathetic stimulation, that fight or flight response, will also affect your preload. Vasoconstriction increases blood return to the left ventricle, increases heart rate, and then increases cardiac output. And then finally, natriuretic peptides. So when atrial and ventricular chambers are stretched, brain natriuretic peptides are released into the system. So this is what you see when you do your blood work, when your patients come in for heart failure. That's what you're seeing in that lab result. So BNP vasodilates, decreases sodium reabsorption, which decreases preload. So medications for preload. Again, when you think of preload, you're thinking of volume in that ventricle. So if you want to increase preload, meaning you need more volume in your ventricle, you're going to need fluids, vasopressors, or blood and blood products. Going back to your volume versus distribution, if it's a volume problem, you're going to give fluids, normal saline, LR, albumin, or blood products. If it's a distribution problem, you're going to need vasopressors. And again, vasopressors will only work, they can only redistribute that volume if you have volume there. And so vasopressors are only effective if the tank is full. So to decrease preload, meaning you have too much volume in your ventricles, you need either Lasix or vasodilators. And so, or diuretics, I should say, or vasodilators. Typically, we would give Lasix. Vasodilators would be nitroglycerin, nipride, dopamine, dobutamine, or milrinone. So afterload, and so when you're talking about afterload is the pressure against which the heart must work to eject blood through the ventricles. So when you're trying to keep preload and afterload right in your head, remember preload is the volume in the ventricles, afterload is the pressure the heart must work against to get that blood out of the ventricles. And so factors that influence this would be systemic vascular resistance, pulmonary vascular resistance, and condition of your valves. And so excessive afterload increases the workload of the heart and increases myocardial oxygen demand. The harder that heart has to work, you're going to increase that myocardial oxygen demand. And so systemic vascular resistance is the pressure that the left ventricle must overcome to open that aortic valve. And so the harder that heart has to work to get blood out of that left ventricle into the body. And so when you think about where that is going, so vasoconstriction is going to increase your SVR and vasodilation is going to decrease your SVR. Pulmonary vascular resistance is the pressure the right ventricle must overcome to open the pulmonic valve. So over time, high pulmonary vascular resistance makes the right ventricle work harder, causing dilation of the right ventricle, requiring more volume to meet the preload needs of the left ventricle. So essentially, your right ventricle is working hard. It's like any muscle, the harder it works, it'll become dilated, and so it requires more volume to fill, and then it requires, in turn, more volume to fill that left ventricle. That's why right-sided heart failure is so hard to manage with your patients, because your heart is very preload dependent, and you can't dry them out too much, but you also have to watch their volume. And so other factors that affect afterload is your aortic valve. And so you can see that top picture there, you have that nice open aortic valve. And then below it, you see that stenotic valve, how much harder the heart has to work to get that same amount of blood through that stenosed valve. And so that's going to affect afterload because that's your left ventricle trying to push blood through that very small stenosed valve. And so interventions for afterload, medications typically you would see would be milrinone, calcium channel blockers, or ACEs and ARBs. They talked a little bit earlier about the intra-aortic balloon pump. Intra-aortic balloon pump will decrease your afterload. And so what happens with the balloon pump, that balloon sits in your aorta, and when it inflates, it allows your heart filling time. And then when it deflates, it actually helps decrease the workload of the heart because it actually kind of sucks the blood out of the ventricle, causes a vacuum effect. And so that's how it helps with afterload. And so another device is the Impella, which we also talked about earlier. It works a little bit different from the balloon pump. The balloon pump is more dependent on your ejection fraction and how well that heart's squeezing. The Impella unloads the left ventricle by actually aspirating blood from the left ventricle into the cannula portion of the pump and then expelling it above the aortic valve into the ascending aorta. And so lastly, we'll talk about contractility. That's how good is the pump. And so it can be decreased due to cardiomyopathy, heart failure, ischemia, AMI, chronic hypertension, hypoxia, hyperkalemia, and hyponatremia. And your contractility is increased due to fear and anxiety, that fight or flight response, elevated heart rate, and hypercalcemia. And so to increase your contractility, you're going to see medications calcium, digoxin, milrinone, epinephrine, dopamine or dobutamine. And to decrease contractility, you're going to see beta blockers, calcium channel blockers, and antiarrhythmics. So mixed venous oxygen saturation. This is how much oxygen is left over after the tissues remove what they need. So a normal SvO2 is 60 to 75%, which denotes tissue oxygen extraction to be 25 to 35%. This means that typically on a regular basis, your tissues are taking 25 to 35% of your oxygen and leaving 60 to 75%. So if you have a decreased SvO2, that indicates an increased oxygen extraction. So you either have decreased oxygen delivery or you have increased oxygen demands. And so what does that mean? So low SvO2 tissues are extracting a higher level of oxygen because cardiac output is not high enough to meet the tissue oxygen demands. So if you have decreased oxygen delivery, that means that you don't have enough oxygen in your system, either due to low hemoglobin from bleeding or anemia, low O2 sat from hypoxemia, or low cardiac output from shock, cardiac dysrhythmias, or left ventricular dysfunction. So if you have increased oxygen demand, that means your tissues are demanding more oxygen than they normally would. So that would be indicative of fever, infection, work of breathing, or agitation. And so if you have a high SvO2, you have increased oxygen delivery or decreased oxygen demand. And so if you have too much oxygen, if your tissues are taking too much oxygen, you probably have a high FiO2 and you just need to come down on your oxygen. Decreased oxygen demand, meaning your tissues aren't requiring as much oxygen as they normally would. That would be from hypothermia. They're cold, so their tissues aren't needing as much. They still have a lot of anesthesia on board, or they still have a lot of neuromuscular blockers on board. And so typically post-operatively, that usually means that we either need to warm them up or the anesthesia needs to wear off. So you will see vasoplegic syndrome. This doesn't happen too often, but you will see this in your post-operative patients, particularly if they've had a long pump run or a long cross-clamp time. So vasoplegic syndrome is the unexpected refractory hypotension following cardiopulmonary bypass. Typically, what the patient will present with in the OR, in the operating room, they'll come to you from ICU and they'll be very hypotensive. You'll give them fluid challenges that they won't respond to. You'll give them vasopressors, which they won't respond to. They're not bleeding, and so there's no clear indication of why this patient's blood pressure is so low. And so once you start giving them all of your normal things and they're still not responding, you can suspect that they have vasoplegic syndrome. First-line treatment for vasoplegic syndrome is methylene blue. One of the reasons it's first line is because it's cheap, easy to get, easy to give. And so it's not a vasodilator. It's not a vasoconstrictor, but it facilitates vasoconstriction and decreases the effects of the vasodilation. And so it can cause arrhythmias, coronary vasoconstriction, increased pulmonary vascular resistance, and worsening gas exchange. It will turn your urine a pretty blue color. Methylene blue is contraindicated for patients taking SSRIs. So if you know that your patient is taking an SSRI, or if you've given the methylene blue and it does not seem to be effective for your vasoplegic syndrome, then you can, your next line would be the high-dose vitamin B12, which is the hydroxycobalamin. And so this drug is not as readily available. It's more expensive, and it's not difficult to give, but sometimes you have to read the instructions if you don't give it very often. And so, but it is very effective. It does work very fast. So just know that if you are given this B12, you definitely need to be ready to turn down your pressors and decrease your volume, because you will see this work very quickly. It will cause, I say may, but it will cause rapid, sustained, and significant increase in blood pressure. And so, and it will also cause your urine to turn red. So if you've given methylene blue, then you'll have pretty purple urine. You do need to watch the kidneys very closely after you give this vitamin B12 as well. And so now we'll talk about medications. And so we'll start with IV fluids, crystalloids. Typically for our patient population, most of the time you're only going to be giving isotonic fluids, which means no fluid shift. You're just giving this for vascular expansion. This is going to be your normal saline, your LR, and this is used to treat hypovolemia from blood loss or dehydration. And so other crystalloids, hypotonic and hypertonic solutions. Your hypotonic solution shifts fluid out of the vessels into the cells. And so this is used to treat cellular dehydration, such as in DKA or hypernatremia. And then your hypertonic solutions is going to shift fluid back into circulation. And so that's, you're going to use these to treat hyponatremia or cerebral edema. Again, you don't see that as much with our patient population, but just so that you'll know the different crystalloids. Colloids are volume expanders. They stay within the intravascular spaces for longer compared to crystalloids. Albumin is the most common colloid that we give. It keeps fluids in the vessels, maintains volume. You do have to be careful with albumin because it can cause fluid overload and pulmonary edema. It is short-acting, and it can increase sodium levels, so you need to monitor your sodium levels when you're giving albumin as well. Blood products, we talked a little bit about this earlier. We have packed red blood cells, platelets, fresh frozen plasma, and cryoprecipitate. Packed red blood cells should be given for active bleeding or anemia caused by open heart surgery. It's typically used for volume replacement. Platelets helps the clotting process during active bleeding, and so you'll see these given when you have when your clotting factors are off. FFP for coagulopathy and deficient clotting factors, and cryoprecipitate helps the clotting process during active bleeding. So vasopressors elevate MAP by inducing vasoconstriction. So typically for your patients, when they come out of surgery, more than likely they're going to be on norepi. They can also be on vasopressin. Those are the two main drugs you'll usually see for hypotension. Inotropes increase cardiac contractility, so your patients who have a low ejection fraction, heart failure, cardiomyopathy, prolonged cross-clamp time, or prolonged cardiopulmonary bypass time. You might see them on these inotropes. What I tell our nurses in our ICU, typically your patients are going to come out on some normal saline and some norepi. If your patients come out on an inotrope or any of those other medications, that's always a good time for you to ask why. Those medications are typically started in the OR for, the patient's right ventricle might be struggling, or they might have had some arrhythmias during the surgery, or things like that. So it's definitely a question. Anytime they come out on an inotrope or anything pretty much other than fluids and norepi, you should definitely be questioning your OR staff, asking them what the reason was for those medications. And so negative inotropes decrease myocardial contractility and decrease cardiac workload. You're going to see these for hypertension, arrhythmias, chronic heart failure. These are usually going to be your oral medications that are going to manage your patients. And so that's going to be your beta blockers, calcium channel blockers, and antiarrhythmics. So vasodilators dilate blood vessels, allowing blood to flow more easily, reducing workload of the heart. This is going to be your nipride, nicardipine, nitroglycerin. Typically, nipride is used mostly to treat hypertension. It decreases blood pressure, oxygen demand, and cardiac output. It does increase your heart rate. Nicardipine, used to treat hypertension. It's a calcium channel blocker and a very potent vasodilator. Nitroglycerin relieves angina and heart failure by causing coronary dilation. You don't see this as much for blood pressure control, but you will see this. Sometimes they will also use this if they do radial harvesting. And I talked really, really fast, and so thank you. Hopefully you were able to stay awake through that, and I'll leave it to Maddie.